Hello everyone and welcome to another video of our internal medicine board review questions in nephrology. This is part 3, electrolyte disorders. I'm Dr. Mohammed Tinawi. I'm a nephrologist in Northwest Indiana. Before we get started, I want to mention that all the information presented today are based on my book, Manual of Fluid Electrolyte and Acid-Base Disorders. You can find this book on Amazon. Please click at the link below. Also, this very YouTube channel has a playlist related to the book, to the fluids and electrolytes, and you can find all the information you need in much greater details. So if you like to know more about physiology, pathophysiology, solve more problems, you can find 10 to 15 minutes short videos, say on the subject of sodium. They are about 14 videos. So please go to that playlist if you're interested. Question 1. A 73-year-old woman underwent left hip open reduction and internal fixation after a fall at home. Post-operatively, a chemistry panel revealed a creatinine of 1.1 mg per deciliter, sodium 134 milliequivalents per liter, and a potassium of 3.7 milliequivalents per liter. What is the most appropriate post-operative intravenous fluid solution? A. D5W or 5% dextrose in water. B. 0.9 normal saline or isotonic saline. C. 0.45 normal saline or half normal saline. D. 5% albumin. Now the answer will be on the very next slide, so you can pause here if you want to think about the correct answer. The correct answer is B, 0.9 normal saline, which is isotonic saline. The reason is simple. This patient is post-operative. Her sodium is already a little bit low, 134, so you want to give her isotonic solutions such as 0.9 normal saline or lactated ringer. Giving her a hypotonic solution like D5W or half normal saline, options A or C, is wrong. Option D, 5% albumin, is not wrong, but colloid solutions are expensive and therefore it's not the best answer. There's no reason for this patient to use a colloid solution. 0.9 saline is readily available and is cheap. Question number 2. So what actually happened to this 73-year-old woman? She did not get 0.9 normal saline or LR. She actually got D5W, the wrong answer. She got D5W at 100 ml per hour. And this patient became lethargic on the third postoperative day. A chemistry panel showed a creatinine of 1.1, sodium 122, potassium 3.5. Now, what is the next step in the management of her hyponatremia? Is it A, IV desmopressin? Is it B, 0.9 normal saline, like the previous answer? Is it C, fluid restriction to 1 liter per 24 hours? Or is it D, 3% hypertonic saline? So you can pause here and the answer will be on the next slide. The correct answer is D, 3% hypertonic saline. The reason being, we have here someone who has symptomatic severe hyponatremia. So sodium less than 125 is severe hyponatremia. Plus here we have symptoms, lethargy. So regardless of the etiology, we are going to use 3% hypertonic saline. 0.9 saline is inappropriate. You can use it later on for maintenance. It's not going to help us much in this situation. Fluid restriction is very inappropriate. It's going to take days before this works, and we want to treat the patient now. Intravenous desmopressin is also inappropriate. The only reason to use it is to slow correction of hyponatremia if we are afraid that we are going to overcorrect. So it has no place here. Question 3. An 80-year-old woman who weighs 56 kilograms is started on 25 milligrams chlorothalidone daily for management of hypertension. Her initial electrolytes panel was normal. 1 month later, she presented to the emergency department with nausea and vomiting due to viral gastroenteritis. Labs showed a very depressed sodium. Sodium 118 milliequivalents per liter. Potassium was also low, 2.3 milliequivalents per liter. Serum osmolality was low, 253 milliosmol per kilogram of water. Urine sodium was 20. Urine potassium was 22 milliequivalents per liter. Urine osmolality was 254 milliosmol per kilogram. And here the question is, how would you manage her electrolyte disorders? Meaning, how would you manage her hyponatremia and her hypokalemia? A, half normal saline at 125 ml per hour plus potassium chloride 20 milliequivalents PO for 6 doses. B, lactated ringer at 150 ml per hour. Remember that lactated ringer has lactate and has some potassium in addition to sodium and chloride. C, fluid restriction to 1 liter per 24 hours and potassium chloride 20 milliequivalents intravenously over 2 hours times 4 doses, so for a total of 80 milliequivalents IV. Or D, 0.9 normal saline at 75 ml per hour plus potassium chloride 20 milliequivalents over 2 hours times 4 doses. So here you really want to pause and think about these different answers, and the correct answer is going to be on the next slide. The correct answer is D, 0.9 normal saline at 75 mL an hour and potassium chloride 20 milliequivalents intravenously over 2 hours for 4 doses. Okay, so why is that? Now, answer A is inappropriate. The patient is severely hyponatremic. Why would you want to give half normal saline? You would make her worse. Moreover, she has nausea and vomiting. You don't want to give that much potassium, 20 milliequivalents PO for 6 doses. That can make matters worse. But really the clue that A is wrong is 0.45 normal saline. You're not going to give a hypotonic solution to someone who is hyponatremic. Lactated ringer is not a bad answer, but it does not address the potassium deficiency. It has some potassium, but if you just give it, you are going to really aggravate the hypokalemia and the patient can get arrhythmias. So you have to address both the hyponatremia and the hypokalemia. Fluid restriction, this patient is dehydrated. She doesn't need fluid restriction. You have to replace her sodium and potassium. Answer D is appropriate because you're doing both. You are giving sodium via normal saline and you are giving potassium. And generally speaking, when someone is hyponatremic and it is due to a thiazide diuretic, we are going to replace with 0.9 normal saline. Now, if the patient has severe symptoms, if you get someone with severe lethargy, someone who's having seizures, you are going to use 3% saline and then move on to 0.9 normal saline like we talked about in question number 2. So this patient has severe hyponatremia and hypokalemia due to gastroenteritis and chlorothalidone. When we give potassium chloride to correct potassium, we are also going to raise sodium. So when you're giving sodium, you raise sodium. When you give potassium, the sodium that went into the cells due to the hypokalemia is going to exit, and you are going therefore to raise the sodium. For more details, please look at my book or at the electrolyte playlist I mentioned. So here we are going to give 4 doses of potassium chloride. Okay, each one is 20 milliequivalents, and each one is in 100 ml. So we are going to give that over 8 hours. Okay. Additionally, over that 8 hours, we are giving 0.9 saline, 75 mL per hour. So over 8 hours, the total volume infused is 75 times 8 from the normal saline, and then 4 times 100 from the potassium, for a total of 100, for a total of 1000 ml. Now, the change in serum sodium, like I said, you have to take into account the infusate sodium, how much sodium you're infusing, and the infusate potassium, how much potassium you're infusing, minus current sodium, and you divide that by total body water plus 1. The 1 is the 1 liter that we gave. So how much sodium we have in 0.9 saline? We have 154. How much potassium are we giving? Well, it's 20 times 4, so it's 80. Minus 118, this is the sodium she came with, divided by 28. 28 is the total body water. So she weighs 56 kilograms, divided by 2 in women, the total body water is half, so 28, plus 1, the leader we're giving, and we get 4. So this regimen will raise her serum sodium by 4 milliequivalents per liter over the first 8 hours, which is very desirable, okay? So sodium and potassium should be checked every 4 to 6 hours, and then we adjust the replacement accordingly, okay? If we're happy with this rate, we'll continue, okay? We'll check the potassium. We can give more potassium. If the nausea and vomiting resolved, we can go to oral potassium. And the 0.9 saline, we can go up and down depending on the situation. We can change to 0.9 saline with 20 milliequivalents of KCl if appropriate. So we have different options depending on the labs, but you really need to check labs every 4 to 6 hours. Now, if we don't take potassium into account, we reach an error, because if you just do the above equation and if you eliminate the 80, you get a rise in sodium by only 1.2, and that's wrong. That may give you the erroneous conclusion that you have to use 3% saline, and therefore you can overcorrect hyponatremia. Question 4. A 50-year-old man presents with hyponatremia following subarachnoid hemorrhage. Sodium is very low, 120 milliequivalents per liter. Serum osmolality is also low, 255. Urine sodium is elevated, 82 milliequivalents per liter. Urine osmolality is 444 milliosmol per kilogram. Supine blood pressure is 105/62, and sitting blood pressure is 90/51. What is the etiology of his hyponatremia? A. Syndrome of inappropriate secretion of ADH, SIADH. B. Cerebral salt wasting. C. Low intake of solutes. Or D. Thiazide diuretics. So here you might want to pause the slide to think about the answer, and the answer will be on the very next slide. The correct answer is B. Cerebral salt wasting. So really here the big clue is subarachnoid hemorrhage. Now the main problem is to differentiate SIADH from cerebral salt wasting. Now, is it C though, low intake of solutes? Absolutely not. Look at the urine osmolality, it's 445. This is not low intake of solutes. This is very normal. If urine osmolality was say 200, then yes. So this is not the cause of hyponatremia. D, thiazide diuretics. Well, in the STEM, I didn't tell you that the patient was on a thiazide diuretic, and really I didn't give you the potassium in the urine, in the serum. So there's really no reason to think that the patient is on a thiazide diuretic. So I would eliminate D immediately. So now how can we differentiate A from B? Here's the problem. Both SIADH and cerebral salt wasting are associated with hypotonic hyponatremia. So sodium is low, serum osmolality is low. Both have high urine sodium and both have high urine osmolality. We differentiate them based on their volume status. SIADH is by definition euvolemic. It's euvolemic hyponatremia. Cerebral salt wasting has to be associated with volume depletion. These patients are dehydrated. The clue here is orthostatic hypotension, okay? So this patient has hyponatremia due to cerebral salt wasting from subarachnoid hemorrhage. If you ever see a case, you will not forget it. Sometimes urine sodium is extremely high. Sometimes you have to give a 0.9 saline or even 3% for a long time. I have to say that most patients with neurological conditions have SIADH, and you're going to see probably 100 cases of SIADH before you see one case of cerebral salt wasting. But the buzzword here is subarachnoid hemorrhage and then orthostatic hypotension. That would really point you towards the correct answer. Question 5. A 60-year-old man who weighs 80 kilograms presents with a seizure. Serum sodium is 105 milliequivalents per liter, so very low. He has been on sertraline for major depression, and he was started on hydrochlorothiazide for hypertension 1 week ago. What is the best approach to his management? A. Obtain serum and urine osmolality, urine sodium and potassium, then determine the next step in management. B. Tolvaptan, 30 milligrams daily, C, 0.9 normal saline at 200 mLs per hour, or D, 3% hypertonic saline. You can pause here. The answer will be on the next slide. The correct answer is D, 3% hypertonic saline. So if you were paying attention to the first set of questions, I said when we have severe hyponatremia and symptoms, here you have a seizure, you are going to use 3% hypertonic saline. So the correct answer is D, no question about it. Now, A is very inappropriate. You have someone seizing and you want to get the lab results first. That can take an hour or two, so it's very inappropriate. B, tolvaptan, you can use it for SIADH or hyponatremia associated with congestive heart failure, but the patient has to be stable, okay? Relatively stable, not someone who's lethargic, who's in a coma, who is having a seizure. So tolvaptan is inappropriate. 0.9 normal saline at 200 an hour is not going to solve the problem. The sodium is very low, it's 105. Why did we get into this mess? Because this person is on sertraline, which causes SIADH, and on top of that, he was put on hydrochlorothiazide, which can lower the sodium. So now you have two agents, two medications that can result in hyponatremia. So you add them together and you end up with disastrous hyponatremia. Question number 6. So we have the same patient, and now we want to give this patient 3% hypertonic saline. How do we do that? A, 3% saline at 100 ml an hour for 6 hours while we're checking sodium every 2 hours. B, 3% saline 100 ml over 10 minutes, then at 35 ml an hour for 10 hours. Also, we check sodium every 2 hours. C, 3% saline 50 ml over 10 minutes for 3 times. Or D, 3% saline at 150 ml an hour for 4 hours with desmopressin 1 milligram IV every 2 hours, every 12 hours. So here you want to pause to think about the answer, maybe do some calculations. The correct answer will be on the next slide. The correct answer is B, 3% saline, 100 ml over 10 minutes, then at 35 ml an hour over 10 hours, check sodium every 2 hours. So regardless of the answer, we are going to check sodium every 2 hours, definitely no more than every 4 hours. And since this patient is having a seizure, we are going to start with a bolus, 100 ml over 10 minutes, and then we slow down the infusion. So option A, 3% saline, well, we're not giving a bolus, okay? We want to give the first amount of 3% quickly because of the seizure, and also we would be overcorrecting, and we'll see that when we do the calculation. So A is inappropriate. C is not the best answer. You are giving a bolus, 50 ml, not too bad, but 100 would have been better. And here you're stopping after 3 boluses. The patient needs more. D, 150 ml an hour for 4 hours also is too much. It's not correct. You will be overcorrecting. Now, when you're giving desmopressin, 1 milligram IV every 12 hours, you slow down the overcorrection. But why do you want to overcorrect and then slow it down? Just calculate correctly, and then if needed, you can add desmopressin. Many experts do. So how do we do the calculations? First, we need to determine a target. So on day 1, we want to raise sodium by no more than 6 to 8 mole equivalents per liter. When we are having a problem like a seizure, our immediate goal is to raise sodium by 5. 5 is enough. We don't need to raise it by any amount higher than that. Now, know the amount of sodium in HIV solution. So in 0.9 saline, we have 154 mole equivalents of sodium and the same of chloride. If you have half normal saline, divide by half. So you have 77 mole equivalents per liter. For 3% saline, we have 530 mole equivalents of sodium. Okay, total body water, you take the weight and you multiply by 0.5 for women, by 0.6 for men. Now, calculating the volume is now easy. The volume of 3% saline, this is the infusate, this is what we're infusing, is 80 times 0.6 because this is a man. The desired sodium is 110 because we want to raise it by 5 minus 105, which is the current sodium, we know that, divided by sodium in the 3%, and I just said it's 513, times 1,000 to get it in mLs, so it's 468 mLs. We are going to give the first 100 of this whole volume over 15 minutes due to the seizure, okay, so quickly. And then the rest of it, we are going to slowly infuse over 10 hours at about 35 ml an hour. We'll check sodium every 2 hours. Now, when you're giving 3% saline, always put a time limit on the order, okay? Give it over 4 hours, over 5 hours. Also put a stop point. So you say if sodium is above 110, discontinue 3%, because you might reach your goal in 2 hours, in 3 hours. It may not take 10 hours. So this way the infusion is stopped. It's critical to keep checking sodium and make adjustments. Question number 7. An 85-year-old woman with advanced dementia was sent to the emergency department from a skilled nursing facility due to obtundation. Her serum sodium was 181 milliequivalents per liter. Urine volume was 1 liter per 24 hours. Urine sodium 10, urine potassium 12, serum albumin was low at 2.1 gram per deciliter. The patient weighs 56 kilograms. Blood pressure on admission 121/68. How should her hypernatremia be corrected in the first 24 hours? A. You give 0.45 normal saline at 100 ml an hour. B. D5W at 200 ml an hour. C. Lactated ringer at 150 ml an hour. Or D. 5% albumin at 100 ml an hour. So think about these 4 options, and the answer will be on the next slide. The correct answer, of course, you give D5W at 200 ml an hour. Now, option A is not the best option. You are giving half normal saline, so there is enough free water, but the sodium is extremely high, 181, and blood pressure is good. So if her blood pressure, say, was very low, you have to start with saline, even though her sodium is very high. You want to support the circulation first. If her blood pressure was marginal, 0.45 normal saline probably would be a good answer. But since her blood pressure is good, I would go with the 5% dextrose in water, or answer B. Lactated ringer is inappropriate because the tonicity is close to normal saline, and again we have severe hypernatremia. Answer D, you might say, well, her albumin is low, why not give albumin? Again, this albumin is in sodium, and it is like giving 0.9 saline, so it will not help with the hypernatremia. It will take a very long time to correct this very high sodium. Now, how do we calculate water deficit? You take current total body water, and you multiply that with current sodium divided by 140 minus 1. Now, the patient is a woman. She weighs 56 kilograms, so we multiply that by 0.5. If she were a man, you multiply the weight by 0.6. Then we have current sodium, which is 181, divided by 140, which is normal sodium, minus 1. And with the simple calculation, we find out that her water deficit is 8.2 liters. Okay, now this is not it. You have to add insensible water loss, and generally speaking, it's about 800 ml or 0.8 liters. And then you have to add the volume of water lost in the urine. Now, we said that her urine output is about 1 liter. So here we calculate something called electrolyte free water excretion. Meaning, imagine that the urine consists of 2 compartments. One compartment is free water, and the other compartment has the sodium and the potassium in a titer equal to that of the plasma. So this is the electrolyte free water formula, and the formula you see on the screen, and with that we get that free water in the urine out of 1 liter is 870 ml, and the rest is the portion that has the sodium and the potassium. Now, I know that this may not be very clear, but I have a video on this formula, also on osmolar clearance, free water clearance, electrolyte free water clearance. So these 2 videos, each is 15 minutes, and I'm going to provide a link, and then this concept would be very clear. So the total volume of water needed is not just the 8.2, the water deficit, but we have to add how much free water is in the urine and how much there's free water losses, okay? Obligatory losses from breathing, sweating, etc. And the total comes to about 10 liters. So in the first 24 hours, you are going to replace by about half that volume, by about 5 liters. And if you divide that by 24, you come up with about 200 mLs an hour. Okay, but again, intuitively, you can come up with that answer, but I'm providing here why it is the correct answer. Moving on to question number 8, here we have a 44-year-old man with bipolar disorder who's been stable for 3 years on lithium. He's complaining of frequent urination. We did a 24-hour urine collection and urine volume was high, 3.2 liters. Urine sodium 35 milliequivalents per liter, urine potassium 33, urine protein is 13 milligrams per 24 hours, which is normal. There's no glucose in the urine. Urine osmolality is 180 milliosmol per kilogram. Serum sodium is 144, serum osmolality is 302. How would you manage his condition? Meaning, how would you manage his frequent urination? A, discontinue lithium and start sertraline. B, restrict fluids, his fluid intake to less than 2 liters per 24 hours. C, give amiloride. D, give hydrochlorothiazide. So think about these 4 options, and the correct answer is on the next slide. The correct answer is C, amiloride. If you discontinue lithium and start sertraline, sertraline is really not a treatment for bipolar disorder, it's a treatment for depression, and the patient is stable on lithium, so A is not a good option. B, if you restrict his fluid intake, his sodium is going to go up, so now you're going to have clearly hypernatremia. Hydrochlorothiazide might lower the sodium, but it really does not address the core of the problem. So why C? The patient has nephrogenic diabetes insipidus due to lithium, meaning because of lithium, the kidneys are not sensitive to vasopressin or ADH. Now, the patient is not hypernatremic because he can drink. If you put him in a hospital and you don't allow him to drink because of surgery, whatever, his sodium will go up. So patients with diabetes insipidus have normal or high normal sodium unless they are restricted, unless their water intake is restricted. So this patient is polyuric, meaning urine volume is over 3 liters per 24 hours. But what kind of diuresis we have? Is it solute diuresis, okay, or is it water diuresis? Now, this is water diuresis. It's not solute diuresis. You've seen that his urine sodium is low, his urine potassium is low, there's no sugar in the urine, there's no protein. So this really goes with nephrogenic diabetes insipidus, and as expected, his urine osmolality is low because the urine is mostly water. Now, why amiloride? Amiloride is a weak diuretic, but it blocks the sodium epithelial channel, the ENaC, okay? And this channel is in the principal cells of the collecting duct, and this is the main entry site for lithium. So now amiloride is going to compete with lithium and lessen the effect of lithium on the kidneys. So it is worth trying. Moving on, question number 9. A 70-year-old woman with SIADH is seen in the renal clinic, so outpatient. She's euvolemic. Her serum sodium is low, 124, potassium 3.8, serum osmolality is 262. Urine studies show urine sodium 95, urine potassium is 53, urine osmolality is 630, urine volume is 1.8 per 24 hours. The patient's blood pressure is 145/85. Serum sodium is not improving even though the patient is adherent to fluid restriction. As you can see, she's on moderate fluid restriction and her urine volume is 1.8, so she's not drinking too much. What is the next best step for the management of this patient? Is it A, fluid restriction to less than 1.2 liters per 24 hours, B, tolvaptan, also known as Samska, 15 milligrams daily for 90 days and then reevaluate, C, dimethylcycline, D, urea packets, salt tablets, and torsemide 10 milligrams daily. So think about these different options, and the correct answer is on the next slide. The correct answer is D, urea packets, salt tablets, and torsemide 10 milligrams daily. So this patient has SIADH, okay? Now, fluid restriction less than 1.2 liters per 24 hours is very poorly tolerated. Moreover, it's not going to work. I'll show you why in a second. But in general, you look at the urine osmolality. If urine osmolality is over 500, fluid restriction alone is not going to work. So just looking at that, it's not going to work. Another way to look at it, you add urine sodium and potassium. So urine sodium is 95, added to urine potassium, you get 147. This is higher than her serum sodium of 124. If you have that also, fluid restriction is not going to work. Okay, tolvaptan, 50 milligrams daily for 90 days, then reevaluate. Tolvaptan is a good treatment for SIADH. However, you have to start that in the hospital, and it's only approved for treatment for 1 month. You need to monitor liver enzymes. So that's the wrong answer. Meclocycline is even a worse answer, much worse than tolvaptan. This medicine is nephrotoxic, is hepatotoxic, and should probably never be used. So that's not a good answer. The best answer is to increase the water excretion, okay, by using urea packets, which cause osmotic diuresis. So you're pulling the water out. Salt tablets, okay, this also will pull the water out and you decrease urine osmolality. And torsemide. Torsemide is a loop diuretic. You can use it a low dose, and that also would lower urine osmolality and increase water excretion. Now, torsemide is not a very bad idea in this patient because her blood pressure is a little bit high. She's not on blood pressure medication, so it's worth a try. If someone is prone to dehydration or their blood pressure is on the low side, I would not use a loop diuretic. Now, another option that might become popular may be an SGLT2 inhibitor, such as empagliflozin and dapagliflozin. There are a couple of recent studies showing maybe efficacy in SIADH. So we'll kind of keep that in mind. It's definitely not FDA approved for that. Let's elaborate further. So patients with hyponatremia due to SIADH, fluid restriction alone is not effective if urine sodium plus potassium is more than serum sodium, or if urine osmolality is over 500. Why? If you use this electrolyte-free water formula that we talked about, you are going to get a negative result. Meaning, and again, I'll provide a link to the video so you can understand that better. Doesn't matter how much you restrict, you are going to absorb some water. So fluid restriction alone is not effective. Again, remember, urine osmolality over 500, fluid restriction alone is not going to work. So we are going to use loop diuretics such as furosemide, salt tablets, urea packets, and maybe in the future an SGLT2 inhibitor. Question number 10. A 50-year-old man with a history of chronic systolic congestive heart failure presents to the emergency department with weakness and palpitations. His medications include furosemide, digoxin, carvedilol, quinapril, and atorvastatin. ECG shows paroxysmal atrial tachycardia with 2-to-1 block. Serum potassium is 2.9. Digoxin level is elevated at 3.1. What is the next best step in his management? Is it A, cardiac pacemaker, B, hold digoxin and administer digoxin immune Fab, antibody binding fragment, or Digibind, C, hold digoxin and give potassium chloride intravenously, or D, check serum magnesium level? Now, this is what his ECG looked like. You can see the 2-to-1 block. So this is like an A wave, atrial wave that is not conducted, and then the other one is conducted. Then the following one is not conducted, then it's conducted. So this is called paroxysmal atrial tachycardia with 2 to 1 block. So every other P wave is conducted, and you can obviously see that the patient is tachycardic. So you can think about your answer, and the answer will be on the very next slide. The answer to question 10 is hold digoxin and give potassium chloride intravenously. Answer A is way too premature. You're not going to put a cardiac pacemaker. You know exactly what's going on. Giving digoxin immune FAB FOB, this is also premature. The digoxin toxicity is not that severe. You haven't tried anything else. This is very expensive, may not be immediately available. Maybe if you try other things and they don't work, you can consider it. Here you really have to hold digoxin and give potassium chloride intravenously because you have an arrhythmia. So you have to give it intravenously. You can do oral and intravenous, but you have to give it intravenously. So I would give 20 milliequivalents intravenously over 2 hours times 2, and then check a potassium, and then continue to replace. Now, option D, checking magnesium level, is not a bad answer, but it's not the best answer. It's possible that magnesium is low and you have to replace it, but here you have your first priority is to replace potassium intravenously, and then you can worry about magnesium. So that's it for this question. We'll move on. Question 11. A 76-year-old woman with chronic systolic congestive heart failure or heart failure with reduced ejection fraction only 20%. She's on furosemide, bisoprolol, and sacubitril valsartan or Entresto. On a routine chemistry profile, her serum potassium is 3.4. Blood pressure is 144/93. What is the next best step in her management, in the management actually of her heart failure with reduced ejection fraction? Do we add amiloride? Do we add spironolactone? C, we give potassium chloride? Or is it D, we add an SGLT2 inhibitor, or such as dapagliflozin? So you can think about these 4 options, and the correct answer is option B, spironolactone. So option A, amiloride, will preserve potassium, so you can correct maybe the mild hypokalemia, but this will not improve morbidity or mortality of congestive heart failure with reduced ejection fraction. Giving potassium chloride will not lower blood pressure and will just address the potassium problem, but again will not reduce mortality. Dapagliflozin probably is a good idea, but now your first priority, the very next step, is remedying the low potassium. So she's already optimized with the sacubitril valsartan, with the bisoprolol. So you add spironolactone, and then maybe you think about adding a dapagliflozin. So this patient has chronic mild hypokalemia, plus blood pressure control is suboptimal. So spironolactone is appropriate for this patient. We have uncontrolled hypertension. Our goal should be 130/80 in this patient, and we have mild hypokalemia. So spironolactone is going to reduce morbidity, is going to reduce mortality, is going to reduce blood pressure, and going to correct hypokalemia. So you get all that, and it's very cheap. The Renal study, published in 1999 in the New England Journal of Medicine, you should be familiar with it. And since we're adding spironolactone to someone already on valsartan, we should monitor for hyperkalemia, even though the patient now is hypokalemic. Now, moving on to the next question. 12. A 20-year-old woman presents with weakness and nausea. Her blood pressure is 105/52 millimeters of mercury. Electrolytes, sodium 139, potassium 2.7, chloride 109, and bicarbonate 21. An ion gap, which is sodium minus chloride plus bicarb, is 9 milliequivalents per liter. Urine electrolytes, sodium is 50 milliequivalents per liter, potassium is 11, chloride is 70. If you calculate the urine anion gap, you add urine sodium plus potassium minus chloride, and you get a -9. milliequivalents per liter. So here we replace potassium orally and intravenously because the potassium is 2.7. So that's all great. What is the next best step in her management? A, do genetic testing for Bartter syndrome. B, fractional excretion of magnesium. C, urine drug testing. Or D, screen for laxative abuse. And think about this for a second, and the answer will be on the next slide. The correct answer is D, screen for laxative abuse. Now, if you would like to know how we screen for laxative abuse, I'm going to provide a link to this excellent article, okay, and you can pull that easily on the internet. Option A, this is not Bartter syndrome, as I will show on the next slide, and doing genetic testing would be a waste of time. Calculating fractional excretion of magnesium, well, that's not bad. Her magnesium may be low because she's abusing laxatives, but that will not establish the diagnosis. Urine drug screening, there's really no indication that she's taking drugs, and it's hard to see how that would help us in establishing the diagnosis. Screening for laxative abuse is the right answer. Let's see why. This patient has severe symptomatic hypokalemia. She probably has metabolic acidosis because her serum CO2 is low. Now, the anion gap in the serum is normal, okay? And we have a negative urine anion gap. So when you add all that up, you get diarrhea or laxative abuse. So diarrhea or laxative abuse is going to give you low potassium, is going to give you normal or non-anion gap metabolic acidosis, and the urine anion gap is going to be appropriately negative. Okay, why? Because you have increased ammonium excretion. With ammonium comes chloride, so the chloride is going to be up, and this is an appropriate response because there's nothing wrong with her kidneys. The problem is taking laxatives. Now, Bartter syndrome, you have normal or low normal blood pressure, which we have in this patient, but we have renal potassium wasting. Her urine potassium is 9, so this kind of excludes Bartter right away. So the urine potassium of 9 is consistent with GI loss of potassium because the kidneys are preserving her potassium. Now, Bartter syndrome usually presents with metabolic alkalosis, not acidosis. The clinical picture of Bartter syndrome, if you want to remember this forever, it's like taking a loop diuretic. So when you take furosemide or bumetanide or torsemide, you're going to have renal potassium wasting. You are going to have metabolic alkalosis. You're going to have maybe low blood pressure. Now, type 1 or distal RDA will give you a renal potassium wasting and positive urine anion gap. So this is not consistent with that either. Now, finally, I want to tell you, you are going to see a lot, hundreds of cases of vomiting, bulimia, diarrhea, laxative abuse, use of diuretics, or diuretic abuse causing hypokalemia to see one case of Bartter, Gittleman, or Little syndrome. I've been practicing nephrology for over 20 years. I probably have seen one case of Bartter, one case of Gittleman or 2, and one case of Little syndrome. That's it. And you need genetic testing to prove it. So that's it for this question. Question 13. A 26-year-old man presents with a blood pressure 161 over 101. Initial electrolytes: sodium 144, potassium 3.5, chloride 109, bicarb 29. The patient was started on chlorothiazide, actually started on chlorothalidone, 25 milligrams daily for high blood pressure. 1 week later, his electrolytes: sodium 139, potassium now 2.2, chloride 101, bicarb 32. Potassium was replaced orally and intravenously. What is the next step in his management? A, discontinue chlorothalidone and start spironolactone. B, screen for primary aldosteronism. C, renal arteriogram. Or D, discontinue chlorothalidone and start lisinopril. You can pause the slide here and think about your answer. And the correct answer is B, screen for primary aldosteronism. Now, answer A is not a bad answer. You discontinued chlorothalidone, which aggravated the hypokalemia, and spironolactone is good in preserving potassium. The problem is now you don't have a diagnosis, and once you have spironolactone on board, you have to stop it for 2 to 3 weeks before you can do a workup for primary aldosteronism. So do the workup first, and then you can start spironolactone. Doing a renal arteriogram is not a bad idea. It's super aggressive. This is a young man with high blood pressure, so it's conceivable that he has renal artery stenosis. In women, you can find the fibromuscular dysplasia pattern, and I would start with maybe duplex ultrasound, maybe a CT angiogram, but not right away with the renal arteriogram. Plus, we have to deal with the hypokalemia problem, and because of this presentation, primary aldosteronism is a lot more likely. Option D, discontinue chlorothalidone and start lisinopril, is good. It will address high blood pressure, but again, it will not give you the diagnosis, so it's not the best answer. So workup for secondary hypertension should be considered in any patient with high blood pressure, especially if you have someone with high blood pressure at an early age. Now, many patients like this patient have borderline hypokalemia 3.5, then you start a thiazide diuretic, and now you have severe hypokalemia. Now, this is an indication to do a workup. And what you do, you follow the guidelines by the Endocrine Society, and you can just Google that and you'll find them right away. Basically, you're going to start with checking a plasma renin activity and plasma aldosterone. You calculate the ratio of plasma aldosterone divided by plasma renin activity. If it is high, you proceed with a confirmatory test such as 24-hour urine aldosterone. Once you prove the diagnosis biochemically, then you do imaging. You never, ever, ever do imaging first. You do the biochemical testing first, and then you do imaging in any endocrine type problem. So whether it's primary aldosteronism, pheochromocytoma, doesn't matter, because sometimes you can have an incidental adrenal tumor. Now we will move on to question number 14. A 50-year-old woman was referred to the renal clinic for persistent hypokalemia. She's on extended release potassium chloride 20 ml equivalents twice daily. She is complaining of arms and legs cramping, fatigue, urinary frequency, and nocturia. Blood pressure is 105/54. Labs: sodium 135, potassium very low 2.7. Bicarb is 29. Magnesium is also too low at 1 milligram per deciliter. Calcium is normal at 9. 24-hour urine studies show sodium 130, chloride 140, potassium 45, and then we have a urine calcium of 30 milligrams per 24 hours, which is low. The patient denied using any diuretics, and actually a urine screen for diuretics came back negative. In addition to potassium and magnesium replacement, so you've done that already, what is the next best step in her management? A, amiloride. B, spironolactone. C, genetic testing for Gittleman and Bartter syndromes. Or D, like we saw in a previous question, screen for laxative abuse. Now, I recommend that you pause the screen, look at this carefully, and then choose hopefully the right answer. The right answer is C, genetic testing for Gittleman and Bartter syndrome. Now, why did I choose this question? Well, a discussion of hypokalemia would not be complete without throwing in a Gittleman or Bartter syndrome. So let's enjoy this for a minute. So what do we have here? We have someone with hypokalemia and hypomagnesemia. Both are severe. We have normal blood pressure. The first step in diagnosing the cause of hypokalemia is to know, is it renal wasting or is it GI wasting? Are the kidneys preserving potassium or are the kidneys wasting potassium? So here we have a 24-hour urine potassium of 45, meaning the kidneys are losing potassium, wasting potassium. A normal response would have been a potassium less than 30 milliequivalents per 24 hours. So if that was the case, then you think of a GI loss. But here we have renal loss. Okay, this is number one. Number two, serum bicarb is high. This is consistent, but not diagnostic because we don't have a pH. It is consistent with metabolic alkalosis. Clue number three, we have severe hypomagnesemia. Clue number four, we have high urine sodium and chloride. So we have salt wasting basically. But urine calcium is low. Now, this is not due to vomiting, okay? Vomiting would give you metabolic alkalosis, but then the kidneys would preserve potassium and would preserve urine chloride. On a problem, if you see urine sodium high and urine chloride is low with hypokalemia, it is vomiting because the kidneys are going to excrete the sodium with the bicarb because of the alkalosis, but will hold on to the chloride. So low urine chloride, keep that in mind, is consistent with vomiting. Now, this is not consistent, again, because her urine potassium is high and urine chloride is high, so it's not vomiting. It is not diarrhea or laxative abuse. Like I said, diarrhea or laxative will give you a non-anion gap metabolic acidosis. Here we have alkalosis. Moreover, with diarrhea, the kidneys are intact, so they should preserve potassium, meaning urine potassium would be low, and here it is high. So it's not that either. Now, the first thing that comes to mind in a problem like this would be diuretic abuse. But we said that the patient denied taking diuretics, and we did a urine drug screen, and it was negative. So let's add all these clues. We have severe hypokalemia with hypomagnesemia. We have renal loss of potassium. We have blood pressure on the low side. We have metabolic alkalosis. We have low urine calcium. We have high urine sodium and chloride. All this can be seen in someone taking a thiazide diuretic, but she's not taking a diuretic, so it goes with Gittleman syndrome. In other words, if you want to remember Bartter syndrome, it's like taking a loop diuretic. If you want to remember Gittleman syndrome, rather than remembering all these things, okay, here, remember taking a thiazide diuretic. When you take a thiazide diuretic, you have hypokalemia, hypomagnesemia, metabolic alkalosis, urine sodium and chloride will be high, and urine calcium will be low with a thiazide diuretic. This is why many people use it for hypercalciuria, to lower urine calcium excretion. But you cannot confirm the diagnosis without genetic testing. Now, what is Gittleman syndrome? Gittleman syndrome is autosomal recessive disorder. It's a salt wasting tubulopathy, okay? And this is why you have normal or low normal blood pressure, because you're wasting salt. The gene responsible is the SLC12A3 gene, and this results in dysfunction of the thiazide-sensitive sodium chloride cotransporter in the distal tubule. So it is like taking a thiazide diuretic. Now, late onset and low urine calcium distinguish Gittleman from Bartter. With Bartter, urine calcium should be normal. But genetics testing is the only way to ascertain the diagnosis. Finally, I think this may be useful. Bartter versus Gittleman both give you normal or low blood pressure, hypokalemia, metabolic alkalosis. Both are salt wasting nephropathy. Both are genetic disorder. But with Gittleman, urine calcium is low. With Bartter, urine calcium is normal or high. With Gittleman, urine magnesium is high and you have hypomagnesemia, but in Bartter, urine magnesium is normal, and you probably will have normal magnesium, not low magnesium. And more importantly, if you want to remember this for the next 20 years, Bartter syndrome is like taking a loop diuretic, while Gittleman syndrome is like taking a thiazide diuretic. And that's it for this question. Question number 15. A 45-year-old man presents with a potassium of 6.1 due to rhabdomyolysis. He was given insulin intravenously, glucose intravenously, albuterol, sodium bicarbonate intravenously, intravenous fluids, 0.9 saline, and intravenous furosemide. 2 hours later, his serum potassium has risen to 8 milliequivalents per liter. ECG shows peaked T waves. What should be done next? A. Recheck potassium for confirmation. B. emergency hemodialysis, C, peritoneal dialysis, or D, sodium zirconium cyclosilicate, which is a potassium binder. So think about the answer, and the correct answer is, the correct answer is emergency hemodialysis. Potassium came back at 8, so it's higher. We are going to give intravenous calcium gluconate to stabilize the myocardial membrane. We are going to repeat insulin glucose albuterol, sodium bicarbonate, maybe furosemide, but we have to do emergency hemodialysis. Otherwise, the patient is going to go into ventricular fibrillation. Rechecking potassium for confirmation is inappropriate. You have peak T waves, so you have EKG changes. You know that potassium is high. Peritoneal dialysis, well, he's not on peritoneal dialysis. You don't have a catheter, and it's very slow in removal of potassium, so it's the wrong answer. Sodium zirconium cyclosilicate is a potassium binder. It can be part of the treatment. It may take an hour or so to work. It's going to reduce potassium maybe by 1 milliequivalents per liter, so it's not enough. The correct answer is B. Question 16. A 72-year-old woman with heart failure with reduced ejection fraction 25%, is on the following medication: sacubitril valsartan or Entresto 24-26 mg daily, spironolactone 25 mg daily, furosemide 40 mg twice a day, and carvedilol 25 mg twice daily. Her blood pressure control is optimal. Serum creatinine is stable at 2.4 mg per deciliter. Serum potassium is 6 milliequivalents per liter despite adherence to low potassium diet. What is the next step in her management? Is it A, discontinue sacubitril valsartan, so discontinue the Entresto; B, discontinue sacubitril valsartan and start lisinopril; C, start pteromer, which is a potassium binder; or D, discontinue spironolactone? So think about which is the best option to lower her potassium, and the next slide will show you the correct answer. The correct answer is C, start pteromer, a potassium binder. Why is that? Now, this patient heart failure regimen is really optimized. All these medications, the sacubitril valsartan and spironolactone, they reduce morbidity and mortality. So if we discontinue one or both of them, we are going to do the patient a disservice. Now, she's already adherent to low potassium diet. So fortunately, we have new potassium binders, pteromer or Veltasa. The other one is sodium zirconium cyclosilicate or Lokelma. Both are appropriate for long-term use. So we can use them and continue with what we need to continue. Continue the sacubitril valsartan and spironolactone. Now, we should not use K-Exolate, okay? K-Exolate should not be used probably ever. And there has been issues with the bowel necrosis in patients post-operatively on K-Exolate. Still, I would not use any potassium binder post-operatively, but if you have a patient with chronic hyperkalemia, you can use one of those new binders. Question 17. This is the last question. 61-year-old woman with a known history of end-stage renal disease and non-adherence to her hemodialysis schedule. She presented to the emergency department with generalized muscle weakness, fatigue, and exertional dyspnea. She missed her last 3 hemodialysis sessions. Her labs were drawn, but they are pending. An EKG was done, and you can take a second to look at it. You can pause if you would like. This is her EKG. This is, of course, a true case, one of my patients. So what is the next best step in her management? A, wait for the labs. B, give intravenous calcium gluconate with intravenous insulin and glucose, albuterol, and arrange for emergency hemodialysis. C, give sodium polystyrene sulfonate, SBS or K-Exolate. D, review her medications and discontinue potassium supplements, ACEs, ARBs, if she's taking any of them. Let's review this patient's EKG. You can see we have peaked T waves here, here. We have intraventricular conduction delay. okay, and we have a junctional rhythm. Now, this is one of my patients, and her potassium did come back at 7.4. So the right answer is B. Waiting for labs is inappropriate because you have a medical emergency. Clearly, you have someone who's non-compliant with dialysis. She's going to need dialysis anyway. She has EKG changes. If you wait, if there's a problem with the labs, she can go into ventricular fibrillation and die. So you have to give intravenous calcium gluconate, insulin glucose intravenously, and albuterol maybe as an inhaled treatment, as a breathing treatment, and you arrange for immediate and emergency hemodialysis. Intravenous calcium gluconate is appropriate only if you have EKG changes, and in this case you do. So it stabilizes the myocardium. It doesn't do anything to lower her potassium. Giving K-Exolate is inappropriate because it takes hours to work. So that's not the right answer. Number D, reviewing her medications and discontinuation of any potassium supplements, ACEs and ARBs, is a good idea, but here you have a medical emergency. You have to do that later when you are doing the medications reconciliation. If she's on any potassium chloride, ACEs and ARBs, you're obviously not going to continue that. This is the last question. I hope that was very beneficial to you. Please subscribe to the channel, like the video, send me comments, and I'll see you in the next video.